Excellent. All of you in surgery? Anybody use it in ED?
What's the question?
Anybody use it in emergency? Oh yeah. Oh,
Give it time.
God, girl, you'll see it. We'll talk about that. Yeah, they're supposed to, but yeah, that's a long story. Let's see, where else? Have you? They like sometimes taking C-arms in it, guys. You can lecture too if you want. Thank you. There have been requests in some facilities. They'll ask you to take a C-arm up to either CCU, ICU, because they want to do an invasive procedure. Usually putting in some sort of a catheter, and the doctor feels that the patient is just way too sick to move to a regular fixed room. You always want to check with somebody before you just say yes. There are usually the facilities have some pretty strict rules about that. It usually takes a doctor talking to a doctor saying, no, you're going to transport the patient. You may have to bring half of the unit with them on all the pieces of equipment, but you're taking them from the bed, and you're going to take the patient to our fixed room where we've got everything that we need to go. So just be prepared for that. Okay. Mobile equipment is actually, as you've seen, since that makes this real short, is there anybody here who has not used a C-arm yet? Okay. So, that's all right. You'll get plenty of experience with it. All the different manufacturers have slightly different fronts. The feature that most of them have is you can take like a damp cloth or something, you can actually wipe this off. I wouldn't say it's waterproof. I mean, you can't dump a bunch of water on it, but if it gets a spill, it's flat. Pressure, you've got a readout here that is operated by the buttons. This is not a touch screen. But it's got basic controls. This is your power control, of course, is the dot with a dot in the middle. Red means off. You got some collimation things. This is your, anytime you see a bell with a line through it, that's your timer off. You've got a positioning light if there's one available. You've got contrast change, you go from black to white. You've got different orientations. You can move image, in this case, from one screen to the second screen in a dual screen system. The R always stands for reverse. Collimation in mobiles, there's usually two of them. You have both the blade type, so you can have rectangular fields of view, but there's also usually an aperture control. So that gives the doctor a lot of leeway. And then, of course, you've got your positioning things for turning, extension, and things like that. For this particular unit, these are what drives the direction of the wheels. You notice there's two of them, so the wheels are independent, which is kind of fun. Especially if you have one wheel going this way and one wheel going this way, it doesn't go very far. This would be the lock for part of the C. Down here is usually shelves. I think I've got some more screens for this. Okay. These are the monitors. Usually the systems are all having dual flat panels. Has anybody seen a unit like this on the units in the floor?
Is that a VCR?
Yeah, no, that's a DVD player. You will see sometimes DVD players are on the shelf below. You'll actually see a printer. Yes, we have electronic imaging. Yes, it goes into an electronic file, a PACS system, but surgeons, especially orthopedic surgeons, still like to have something to draw on. So on some of the older systems that are still out there that have either DVD players or printers on them, you will still find physicians wanting to use them. As time goes on, those units are going away because they can do all the things they need to do, especially measurement for orthopedic appliances. Actually can be done on their computers at their desk, and there's a one-to-one correlation. All the major manufacturers of orthopedic appliances can provide templates that are matched for the calibration of your monitor. Yeah, so this is a printer color. This is your power cord, someplace to store your pedals. You can see here, I've got a better picture later, but these are the brakes for the wheels. This is your extension cone for the tube. This is an older unit, so it was made to do both surgical cases and normal cases. As you know, the federal regulations allow that if for a surgical case, if you need to reduce the distance from the tube to the patient's skin, you are allowed to take that extension cone off. However, once the procedure is done, you pull that out of the room and you store it. Before you walk away from that C-arm, make sure that cone is on. California granted a blanket exemption 20 years ago now, but it's still in force, and they will cite for this, that basically says you are allowed to remove an extension cone and reduce the SID if, in the surgeon's opinion, he needs that shorter distance in order to get the tube under the surgical table or for patient care or for whatever reason the doctor decides. But once it's apart, it has to go back on. Inspectors will, some of them will immediately, the first thing they'll do is ask to go upstairs, and they want to walk through OR to see where all of these are stored, and all they do is walk by and look. They want to see a lead apron, and if not on the unit, they want to see someplace where it's easily stored, where people know where they are, and they're going to look to see if it's a type of unit that requires an extension cone and if the cone is on. If it is not on, they will cite you. If it's a repeat violation, they have the right to make you permanently affix it onto the machine, which means you can no longer use it in surgery. So you always want to make sure that those are back on. You can see better look on the wheels. This is a manual brake. These do not brake themselves. You have to actually physically step on this to anchor it in place, and these are your steering wheels here. That's a better view. So these have a lot of different motions. They can extend, so they have a throw, they have an angulation, you can move the C any which way. These are all manual push. So it takes two of you, one to push the C, one to push the displays. Okay.
Sometimes we do both.
I'm sorry?
We do
Or
both.
sometimes you're alone. Yeah, that's always fun. Because then you have to move one at a time. You go back and get the second unit. You usually got somebody in there screaming, "Where is it?" That was my impression of a nurse, surgical nurse. Where is it? They do that a lot. So yeah, so that's each manufacturer. They all look pretty much the same. There's usually a keyboard too. That would be your demographics for the patient, name, hospital number, age, blah blah blah. Usually that should, for a radiology information system, would be called up on the screen, and you would just choose the patient. This happens to be an OEC. This is a system that uses an image intensifier. It does have a CCD camera. That's why it's so short here. So you've got a lens system here, and the CCD is here. And then, of course, that goes off to your digital. This is actually, looks pretty simple. It's a pretty decent piece of engineering. This is lined with a particular metal to decrease the sensitivity of this to magnetic or electric fields. You can tell if the shielding is poor, or you're in an area that has a lot of interference. If you lay something straight, if you turn this around, lay something straight on that surface, you'll get an S shape. And that means you've got magnetic interference for what's going on. You usually have to try to figure out what's causing that. So you do have to make sure that you're outside the 5 Gauss line if you're close to an MR, and that even the 5 Gauss line isn't affecting that. Okay, now this is a special tube. This is made for a surgical C-arm. There is no extension cone. So this can only be used in surgery. So if you try to use this somewhere other than surgery, that's a problem. It's violating the law. So this is set so that this has really, really small, so you can fit under those surgical tables. You got a vent here. Some of these units, the high tension transform is actually in the head of the tube. These things are getting really, really small. I'm used to high voltage equipment that's probably this size, and they've just really gotten down. High frequency transformers are very, very small, about the size of a shoebox. So this is another piece of equipment. I think this is much better laid out. It's simpler, of course. KVP and Fluoro MA show if you're doing exposures. For radiographs, mass will show, otherwise it's MA. You've got image rotation, you've got right-left reversal. Mag mode is indicated here, so you've got normal, mag 1, mag 2. This is for you to save images electronically. This will change images on your workstation. This changes the mode that the display is in. This is your blade collimation. You can actually rotate the blades, which is kind of interesting. This is your aperture control, collimation in and out. Auto contrast, or you can change contrast yourself. Now this is where you get into, you've got pulse mode, you've got low dose, you have film. Film means you're going to take a, in this case would be a CR, KVP control, MR mass, and this is your alarm reset. This is probably one of the easiest systems to understand. I think just about anybody can take this into a room and figure out pretty much what they need to do and how to set what. This is your wheel lock. This is the side that basically hits the floor. Once these are locked in place, you want to make sure they're locked really, really well, and that the unit is pretty much where it needs to be. All the rest of the controls are up above, and you can change orientation, but these are all manual locks. That's something that's different from a regular fluoroscopic unit because those are fixed to the floor. These have manual locks. Okay, so this is, and all of your locks for the most part on these pieces of equipment are manual. So this is your unlock and lock control for orientation. These are not for every single machine. This is an indication of typical. So, orbital rotation is typically about 115 degrees. And orbital rotation is where the C does this. That's orbit, orbital rotation.
So you're talking AP to lateral, AP to lateral?
No. Notice this is typical is 115 degrees. For an AP or lateral, you need 180. So you're going to change the
Talking about that one,
horizontal
okay.
axis rotation. That's where the whole C does this. That's typically plus or minus 180 degrees. A lot of the newer units are plus or minus 210 or 270. Okay. Telescoping is where the entire C moves in and out. Usually, average distance is about 20 centimeters. So it's not a lot, but that allows you to get close, but you don't have to get right up next to where you need to be. You have a little bit of movement there. Side to side is what we call wig-wag. That's where the C does this. It's a wig-wag. It's not much, plus or minus 12, plus or minus 26. Then your height adjustment, where the whole C goes up and down, is typically about 46 centimeters. That would be for a standard size C-arm. That would not apply to what they call the little mini C-arms that they use in
The fluoro,
orthopedics.
the fluoro scan?
Huh?
The fluoros?
Yeah, they're pains. The older ones you can really get hurt on because every piece on that system is a manual lock. So if you miss one, you're going to get a finger caught or it's gonna come down and hit some part of you. I hate them myself. Okay, so this is another dual screen type. Again, you've got your keyboard for doing your patient information. This is a DVD. Doctors like putting together what they call teaching files. So any interesting case that they have, before PACS was widely distributed, we probably still have some small hospitals that have wannabe PACS. But they still like to load stuff up so they can carry that off to a conference or something like that. The problem with that is in a lot of hospitals now you cannot do that on the individual C-arm because of HIPAA. HIPAA requires if they're going to take that study and take it to a meeting and show it, what do they have to do?
You have to erase all the identifiers.
They have to anonymize the image. So they have to get rid of anything that can trace that back to the patient. So that would mean name, medical record number, date of birth, and or age. Get that information off, and you can show these any place as long as you're also not giving a verbal description of the who, what, where, when, and why. Okay. So you can put that in. Then you've got some remote controls you can do if you're not standing at the C-arm itself. Again, probably won't see a lot of these. That's a Sony color printer for medical use. You can get one of these, well before, fairly inexpensively, but for medical use you can take the price and multiply it by a factor about 4 or 5. They were really expensive. Like I said, this is mostly orthopedics still really like to draw. I don't know why. I think it's just the way they're trained. More controls, different types of things. Again, pretty common for contrast to be the circle split in half, one side black, one side white. Here you have a brightness control. You also have an auto control for technique. You have some enhancement controls. This obviously has some pre and post processing on it, so you can change your filtration as far as your noise. So you can, this would be, if I'm going to reduce noise, what do you think I'm typically doing from our last lecture?
Increasing your signal?
Frame averaging.
Oh.
So this is going to get rid of the noise, it's going to determine how many of those pulsed shots are going to be added together to bring the noise down. Okay? As you bring the noise down, what happens is you get more image lag because it takes longer. You've got more frames that are being added together before you add the next set. But that allows you to change your noise. You've got some zoom. You've got some negative. So that allows you to go from white on black to black on white. Allows you to, again, typical thing for saving, swapping monitors. That's a blank button. Some physicians don't like having dual monitors. They're quite happy with either live or goes to last image hold, so they don't really need that second one. So it allows them to blank the second monitor if they don't want to use it, so it doesn't get in their visual way. Patient information, image directory, and image acquisition is all there. And again, these are all things that can be wiped down and cleaned, which is necessary for OR. This is the infamous mini C-arm.
That's a fluoro scan.
Oh yeah. Every hinge that you see is manually locked. And the thing about this that really irritated me, and we reported it to FDA, I don't think they really did anything, is that in your regular full-size C-arms, the image detector side and the tube side are counterbalanced. So if you unlock it, it's not going to go flipping around someplace. This little guy, if you unlock it and you don't know what you're doing, it's going to flip. Because for this one, the tube's up here, it's a smaller tube. The high voltage is up here, so this weighs a lot more than this, and it'll go flipping around. So be really, really careful. So for these, you just My advice is you only deal with one lock at a time. So you move one piece where you want it, lock it, go to the next piece, and at some point, you'll get it. These are usually only used in cast room. Some facilities, they like having these in the ER. Doctors think that it's easier for them if they could just do it themselves. Patient presents with a fracture or something of that sort. They can do a quick peek here and determine what they're going to do with that patient. So from a triage point, that's great. The problem with this is, and we'll get into that, is you may witness a doctor not doing it, but instructing a nurse to do it. Okay. Can a nurse, under any circumstances, ever activate X-ray?
Have a Fluoro license.
Unless she has a license.
Unless they have a license. California passed a physician assistant law some time ago that said a physician assistant whose certification is current can go get additional training for doing fluoroscopy only. They can never take an X-ray. They can never position or take a radiograph. Can't do it. But they can use fluoro under certain circumstances as prescribed by their mentor physician. Every physician assistant and NPA has a mentor physician who signs off on what they can and can't do, and also swears under perjury, blah, 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 that person is qualified to do that particular exam. And the exams have to be very specific. They just can't say authorized to do fluoro. It's authorized to do fluoroscopy of the ankle for determination of fracture. It has to be that specific. If they use it for any other purpose, again, they're violating their contract. So this is pretty much what the new ones look like. There is a printer here for some reason. They still sell them with printers. I don't understand that. Fluoroscopic scatter. This was done with a C-arm. Image intensifier was above. X-ray tube was below. 100 cm SID. Field of view was centered directly over the sternum. So you're basically concerned with mediastinal work. This is a phantom like what you have here. And the poor idiot that did this used a radiation detection device, had the room laid out in a grid, and took individual measurements at certain height off the floor, at certain distances, and then manually plotted that because there were no computer plots at the time. He would never do it again. These are the 20 MR per hour line, 100 MR per hour line, 300 MR per hour line. This is a research unit that allowed fluoroscopy at, I believe, it was 80 kVp at 10 MA. So it was a high output. You needed something high so that you could actually measure the exposure rate. The thing to look at is scatter distribution is related to the shape of what you're fluoroing. So for a body, it's thinner here, so if you're in the midline, obviously you're going to get more scatter because it has less tissue to go through, whereas here, you've got a lot more tissue, so it attenuates a lot more. Okay, there's a lot more tissue to go through, so that gives it that typical butterfly shape. Okay. The cathode side and the anode side, you'll see on the next slide, is slightly different. Anybody think of why that might be?
The intensity's hotter on the cathode side.
No? Hint?
Anodial effect.
Heel effect, yeah. So from the head end, so you got the anode, cathode, so the heel effect does play a part. So again, this lets you know that if you can stand on the anode side of the tube, you're going to get slightly lower exposure than you are on the cathode side. You notice there's nothing above here? Why is that? That's the image intensifier. Legally, under federal law, manufacturing law, the image intensifier has to be constructed in such a way that it meets the requirements for a primary barrier. Okay? That's really important. Tube, of course, has some shielding in the tube housing, but it does not have that requirement of meeting primary barrier. So you can see in this orientation with the tube below and all of that, so imagine a physician standing here, he's got his lead apron on. What's the biggest source of exposure?
Patient or
Well, besides the patient, biggest source of exposure to the physician standing at table side. What's down here? Feet. Lead aprons only go to knee or slightly below the knee. They actually have done some studies reading the radiation exposure to physicians' feet. And some physicians who do a lot of this have actually reported radiation dermatitis. So also something to be aware of. If you're working table side, you want to keep track of, your feet. From the side, again, you can see backscatter for Compton is what? Back towards the source. So it goes back, the primary scatter is back towards the tube. So this is where you're scattered. That's why on units like the one in the back, for the fixed units, you hang drapes here. Lead drapes will cut all of this down. Okay. It's really, really important. But for C-arms, typically they don't use drapes, and they certainly don't use leaded drapes for the most part in OR. Special procedures, some special procedures are using lightly leaded drapes. So they're a sterile drape. They have an alloy in them, not really thick, but it does cut some of that scatter down. They also put that in the patient drapes. Those are available. Problem is, since they're sterile, they can only be used once, and they're expensive. So it does add cost to medicine. Again, you can see no exposure up here. And then, of course, your scatters is butterfly shaped because there's a big barrier there. Okay. So that's typical for that particular procedure. I don't think, I don't have, no, I don't. Okay. If you were to turn that X-ray tube on the side to do a hip or something else, those distributions are very dramatically different. So if you're doing a cross-table exam with a fluoroscopic C-arm, where is the absolute safest place to stand other than leaving the room? Behind the what?
Doctor.
Oh, that's number 2 spot. There's a better spot than that. Not to tube,
As far away as possible.
the image intensifier. The image intensifier is here and the X-ray tube is there. This is the best place to stand. Absolutely. Personally, I would have no problem standing there without lead on. I would feel perfectly safe. Of course, you have to wear lead, it's the law. But why is that? Because the imaging, first of all, the law says a couple of things.
it's a primary barrier.
The law says X-ray has to be confined within the field of view of the image receptor. It can't be bigger than that. And that's tested. Service comes in and does it. Your service engineers for the manufacturer comes in and do it. If you have service engineers in your facility, they do it. You probably all have in your facilities a physicist that's connected with them. They come in and test that. And that's the law. So the X-ray beam has to be confined to that. And the second thing is it's a primary barrier. It has to be equivalent to 2.5 millimeters of lead or more. Okay. We shield walls for X-ray rooms with 2.5 millimeters of lead, sometimes more. But that's a whole different thing. Digital photo spots. To figure out what the patient gets, you need to know what the image intensifier and the optical system is set for. Typically, this is a 14-inch fluoro, so it's 1410 6.5. So in order to get a level of noise that is sufficient for good image quality and yet not overly so, so again, you're trading off image quality noise versus patient exposure. Manufacturer for this particular unit sets that up to about 30 microar per frame. So that means every time an image hits this, it's about 30 microar. 80 microar in 10-inch mode, which is more than twice. 180 microar per frame when you drop down to 6-inch mode. So that's what the image intensifier needs. What that transfers, once you go through the table, which isn't much, okay, the patient, which is a fair amount sometimes. So for your typical patient, anybody remember what a typical patient is? You'll love this.
Not me.
70 kilogram male is typical.
It's like about 150
patient.
pounds.
And kilograms, what, 2.2 pounds? So it's what,
50 some.
150 something? Are there any men in here that are 150 pounds or less?
Huh?
Let's see.
I'm 157.
Well, whoop-de-doo. Here I am trying to lose weight. I'd be ashamed to do something. Just rub my nose in. All right. The important part is the numbers are close. 30, 50, 30, 50, 120, 80, 280, 180. The difference is this is in microar. This is in
Milliar.
MR. Big difference. Okay. So, typical exposure range is somewhere between 1 and 20 milliseconds per frame. If you're doing fluoro, and you're doing, say, angiography, and you're